with the express mini shunt?
The express mini shunt is a modified trabeculectomy, really.
Right.
Essentially, it shortens the amount of time spent in creating a sclerostomy and also allows you to allow controlled flow of the aqueous humor. It concerns me especially about the erosion of these stainless steel implants through the scleral patch graft, through the partial thickness scleral bed that you have created for doing the surgery. Even though the bed has been created and there is a partial thickness scleral flap over it, sometimes the stainless steel implant can erode through, and that can become a problem for causing endophthalmitis. Otherwise, it does shorten the trabeculectomy surgery and reduces the inaccuracies of creating a sclerostomy. Since it is a tube, it can, in many cases, avoid the need for having to do a iridectomy, and that also reduces the amount of iritis that happens following the surgery. But I am still on the fence whether to use that express shunt or not to.
So would you say in a third world country or in a developing country where the cost of the MR valve would be too much, would maybe express shunt be the way out?
I think we are talking about two different things entirely, because the express shunt is a modified trabeculectomy. So in a developing country, to reduce the cost and conserve resources, I think it is better to do a trabeculectomy where there is no added cost of an implant and it is not easy for the patients to come back for a follow-up. Having a stainless steel implant in the eye can be risky to certain patients, and if they don't follow up when they get a problem, they could lose the eye. Right. So I'd rather do a standard trabeculectomy with mitomycin C and give them the best chance. And if the patient is able to afford an armored implant, yes, definitely to consider an armored implant. But otherwise, a trabeculectomy still would be the mainstay in glaucoma management.
So some prostaglandins are being shown now that they have a 72-hour effect. So would this affect your decision-making on choice of prostaglandins?
Yes, certain prostaglandins have been shown to have a longer term effect than the 24-hour typical lifespan of the drug.
Right.
Travoprost is one such drug that shows the effectivity at least for 36 hours. The implication of these longer action of these types of drugs, like travoprost, is that the peak and trough effects of the drug are almost equal. That means the fluctuation between the peak effect and the trough effect, which is 12 to 24 hours later, there is not much difference. That means this pressure remains stably low. And that is important because, as I and many others have shown, intraocular pressure fluctuations can be significantly detrimental. You don't want a drug that is very effective at peak, but then it loses its effect at trough.
Right.
And that indicates much more diurnal variation. You'd rather want a drug that is more stable.
Right.
Additionally, it becomes an insurance against patients who will occasionally miss an eye drop. We all know our patients all miss eye drops, including us if we have to take them. So a drug that is lasting longer than 24 hours gives some sort of an insurance if the patient does miss an eye drop that the effect is not gone away, that the effect is just marginally lesser compared to a drug that acts for about 24 hours or less.
So when you consider a timolol prostaglandin combination, would you prefer to ask the patient to put this drop in the AM or the PM?
I prefer to tell my patients to put it in the AM, and that's because I prefer my beta blocker drugs to be used in the AM, because I do not like them to be used in the PM because of their effects sometimes on their blood pressure. So I prefer that in the morning. It is also another preference of mine that they use it in the morning because patients tend to forget their drops at night time. If it's the last thing that they have to do before going to bed, many times the patient will forget the drop and find next morning that they're taking it because they forgot it last night. And therefore I try to tell them to make it into a routine habit of taking it in the morning in association with brushing the teeth or some other morning activity that they do, like putting on their glasses or something like that, that they keep the bottle there. That way it reminds them it's done for the day, and they don't have to worry about it. Oh, I must not forget, before I go to sleep I have to put this eye drop. It takes away one burden and therefore improves compliance.
Dr. Asrani, do you really feel that non-penetrating surgery is relevant in today's surgical setup?
Non-penetrating surgery, if it is quick and successful in terms of pressure lowering to the extent of what we get with trabeculectomy, then yes, it will have a major effect in our management of glaucoma patients. But so far, the pressure lowering with a non-penetrating glaucoma surgery is not as much as what we get with a trabeculectomy. And it is equivalent sometimes to a drug or drug and a half. And therefore, I am having a difficult time justifying patients to undergo surgery and take the risk of all the complications of surgery, even though the risks are lesser with non-penetrating surgery, to convince a patient to take that risk when the pressure lowering is not that much. On the other hand, in a developing country where the drugs are not as easy for the patient to afford and take and be compliant, if a non-penetrating glaucoma surgery can be done reliably by the surgeon, it can take the place of medicines, and since it is non-penetrating, can reduce the chances of complications. So the other factor that one has to look at is the time it takes to do these surgeries. If it is less time intensive, makes it more easy for the surgeons to do that.
So with genetic screening being available today to all neonates, do you think that is the way to go? Should we screen everybody, and maybe that will help us manage our glaucomas better and differently?
Genetic screening for glaucoma, though, is very promising, but has not yet shown us any significant benefit, because the percentage of patients having positive genetic tests, even though they have glaucoma, is very little. And even in adults, it is not very commonly present, those genetic mutations. So therefore, I don't think that we are going to be, in the near future, doing genetic testing for neonates for glaucoma. I think we have to do a lot more genetic research, come up with things that are common in genetic testing among our glaucoma patients, and then we might consider the possibility in the future.
So research is now linking glaucoma with Alzheimer's disease. Do you feel that glaucoma is really a degenerative disorder?
Yes, glaucoma and Alzheimer's disease have some things in common, such as loss of white matter. And the other is the bio reaction in these two diseases, that is the collection of amyloid in both in glaucoma and Alzheimer's disease. Patients with Alzheimer's disease have also been shown to have a dropout in their nerve fiber layer density around their optic nerve compared to other patients. So there are these two areas in which quite a bit of overlap is there between these two diseases. And therefore, there is some question and talk about possibility one being related to the other. Both are neurodegenerative diseases, both are related to older age, and could it be a immune reaction of the body to certain cells? Could it be a biomimicry of something that might be common to both mechanisms? It is possible.